Hi, everyone. We're not starting yet, but I just have a quick thing. Is Amanda Lindo in this room? Can you raise your hand? Uh, Thank you. Everybody hear me? There we go. Good morning. On behalf of Symposia Medicus, I would like to welcome you to our Summer Women's Health Conference. I expect we're going to have a great time over these next 4 days. My name is Angie Dimitri. I am the conference director this week, so if you have any questions at all, please feel free to come and see me or Nick, who's down at the registration desk. We are going to be in this room the entire time, so all our general sessions will be here. Their schedules posted. They're also on the QR code. The schedule is there as well, so today we'll be ending about 1:30. Tomorrow we're here at 8 o'clock again. Friday we do start in the afternoon, so just be aware we start at 3 o'clock, and then Saturday we're back here at 8 o'clock. I do want to stress how important that QR code is. That has the evaluations, the surveys. We really do like to hear your input, and we do need the information for your CME. On Saturday, we will send you an email that has the verification of attendance form that you will need to get your CME credit. So you don't need to sign in. Just make sure you fill out that form on Saturday. It doesn't have to be done on Saturday. You can do it when you get back, but that QR code is really important. That has everything that we need for you and information too about the conference area, a lot of information there. So we look forward to having a great week. I also want to remind you that there are yellow question cards inside your badges, so we will have Q&A sessions with our faculty. If any questions come up that you can think of that you want to ask them, please feel free to jot them down. I'll go around and collect them, and then they will answer those questions during the Q&A. I would also like to welcome everybody that's watching from us virtually for our conference. So there are quite a few people that are watching. If you have questions as well, please jot those down. We will not jot those down. There's a chat box that you can put your questions in, and we will answer your questions as well. So welcome to all our virtual attendees also. Internet access, if you're not staying on property, the Wi-Fi is called Conference. You will see it, it's Palisades Tahoe Conference, and the password is welcome with an exclamation point and a capital W. I have that written down as well, so if you need the Wi-Fi, that is the information. Tonight, we have our reception. It's going to be at 5:30. Your family is welcome to attend. It's going to be at the KT deck, which is back in the village. So in the village, when you see the entrance to the aerial tram, if you just go up that hill to the right, you will see a big building that says Olympic House, and the deck is right outside off of that. If the weather is a little iffy, we will be inside in the Olympic House, but it's in that same area. So that's from 5:30 to 6:30 tonight. There's appetizers and drinks. So again, everyone is welcome to attend, including your family. And speaking of the tram, we do have discounted tickets. You do have to go online to buy those. You cannot get them at the box office. So again, in that same QR code, there's a travel link. Make sure you go to that link, and it has the information you need just to buy your tickets online, and those are discounted. Finally, I do want to introduce one of our co-chairs, Dr. Bates. Dr. Bates was born in Boston and spent the majority of his childhood in Huntsville, Alabama, after his father migrated south to join NASA and the space program. He received a BS in biology from Rhodes College in Memphis and his MD from the University of Alabama at Birmingham. Following OBGYN residency at the University of Tennessee Health Science Center, he practiced OB in rural Georgia before his reproductive endocrinology and infertility fellowship at Brigham and Women's Hospital at Harvard Medical School. Dr. Bates is currently the Grimes Family Endowed Department Chair of OBGYN of Baylor Scott and White Health and Professor of OBGYN at Baylor College of Medicine. He is a board-certified specialist in OBGYN and subspecialist in reproductive endocrinology and infertility with numerous teaching awards. Dr. Bates is an active clinician and lecturer, and I'm happy to announce that today marks Dr. Bates' 200th national talk. So we are more than happy to welcome Dr. Bates. He has spoken for us many times, and I'm going to turn it over to him.
Good morning. Thank you. I'm thankful to my mom. She wrote that, so anything that's not true, we'll talk to her. And 200 times means I'm old and hopefully, but not forgetful or shaky yet. So thank you. What a great group here. Looking at you, we have representatives from 43 states and 3 countries and just a wide range of physicians, nurses, advanced practice professionals, and look forward to learning together. I'm also incredibly excited about the faculty I've had the opportunity to give lectures with two of them, and I honestly learned far more than I presented in my talk. So I'm excited. I've got my pen ready, computer open, and going to take lots of notes. So I think it's going to be a good few days. We have a treat starting with Dr. Freebie, although I read his bio this morning, so I stayed out of that room on the left with the danishes and sweets since we have a diabetes expert. But he tells me it's a no judgment zone. So this is also the first meeting that I've brought glasses to the podium. If anybody else feels my pain, it's a new thing. So Dr. Freebie is a clinical professor of medicine and director of the Gonda Diabetes Center and director of diabetes clinical programs at David Geffen UCLA School of Medicine. He completed his residency in internal medicine at UC San Diego and a fellowship in endocrinology, diabetes, and metabolism at Columbia University. After training, he joined the faculty at Columbia University, specializing in diabetes care and research at the Naomi Berry Diabetes Center. In 2014, he moved west and joined UCLA and now leads the diabetes clinical programs, collaborating with the Department of Medicine quality team to improve diabetes access and care throughout the health system. He has also conducted diabetes-related stem cell research as well as evaluation of non-invasive measures of beta cell mass to help further define the disease. More recently, his research has focused on hyper and hypoglycemic risk in skilled nursing facilities, as well as improving eye and kidney screening measures at the population health level. I'm a little bit of a stalker, by the way, for the speakers, so I went online and was incredibly impressed with all the patient feedback, and across the board got 5 stars, which is impressive. And I love some of the comments about excellent, clarity of instruction, communicates great. And here's the tough one for us. One patient said, "You always listen." So we look forward to learning and listening to you today. Thanks for being here.
All right, testing. Can you all hear me? Perfect, Asha. All right, great. Dr. Bates, thank you for that incredible introduction, and thank you to Symposia Medicus for the invitation to speak here this week. So I am starting this off, the first of 4 of my endocrine-related lectures this week with osteoporosis, and I do hope to provide you with some of the basics, as well as some cases beyond kind of those basics, really to kind of better understand kind of some of the more difficult cases that we need to understand and potentially treat for our patients to keep them healthy, reducing that fracture risk. All right, so those are my disclosures, objectives. I do hope to describe comorbidities related to fracture, as well as define the osteoporosis, as well as how to identify fracture risk in our patients. Discuss the pharmacologic therapies, benefits, risks of them, as well as provide guidance surrounding denosumab discontinuation, I think is very important, as well as the discussion related to bisphosphonate holidays. So as we age, women over the age of 55, men over the age of 65, we start to see an increasing risk for fracture. It's estimated that 1 in 2 women and 1 in 5 men will ultimately sustain an osteoporotic fracture during his or her lifetime. Morbidity is significant with fracture risk. We see a reduction in quality of life, an increase in pain, reduction in functional status, as well as potential for surgical fixation. There's a twofold increased risk for hospitalization over 8 years after a fracture. And after that index, after that first fracture, there's increased mortality risk for 5 to 10 years. For those who have a hip fracture, there's a 1 in 4 risk for mortality within 1 year. So osteoporosis comes with significant morbidity as well as mortality, and costs continue to rise, greater than $95 billion by 2040. Despite that, there are gaps in osteoporosis treatment, and this data is a little bit dated, but I think that it still holds. Getting a little bit of feedback. Is it working? All right, sorry. The data is a bit old, but I do think that it still holds in terms of some of the gaps. And again, trying to paint that picture that osteoporosis treatment is really important, but probably we're not doing our best in terms of providing that treatment to reduce the risk for fractures, in particular in our aging adult population. So this is data from Solomon and colleagues from 2002 to 2011, in which they looked at beneficiary data for women who were admitted for hip fracture between 2002 and 2011, and then followed them over 1 year to assess if they were prescribed a medication for the treatment of osteoporosis. During the life of this review, only 30% of women were prescribed a medication for osteoporosis. Even more so, by 2011, only 1 in 5 women were actually prescribed a medication for the treatment of osteoporosis. Why is this? And again, these patients are really high risk for recurrence and fracture. These are the ones that you really want to potentially prescribe a bisphosphonate for. What is it? Well, we have both patient and provider concerns in terms of adverse events during this time, and ongoing the concern related to atypical femur fractures as well as osteonecrosis of the jaw. And I'm going to provide you some of that data really to hopefully show you that the risk remains very low, as well as confusion about the medications. What are the benefits? What are the benefits to each of those sites on the bones? And I think that it's really important that we consider treatment. So how do we define? Well, in 1993, the conceptual definition was provided with a low bone mass with microarchitectural deterioration of the bone, increasing fragility and ultimately increasing the risk for fracture. 1 year later, the World Health Organization set forth operational criteria that allowed for epidemiologic studies to go further, as well as for us as providers to prescribe medications. The workhorse for essentially the diagnosis of osteoporosis is a bone mineral density, and defining osteoporosis is through that T-score, majority of which osteoporosis is defined as a T-score of minus 2.5 standard deviations or lower. T-scores are defined against that of a young, healthy female. In some situations, in premenopausal women, younger men, we can consider Z-scores. These are against age and gender-matched peak bone mass. And the definition's a little bit different, but those who are high risk for fracture with Z-scores are those minus 2.0 standard deviations or lower. So again, how do we define? We have osteopenia, minus 1 to minus 2.5. We have osteoporosis, minus 2.5 or lower. And generally speaking, osteoporosis is at that level of treatment. But before we talk about treatment, I want to talk about some of the keys to fracture prevention. Not surprisingly, smoking avoidance or cessation are important actually for pretty much all of life and multiple chronic diseases. But in osteoporosis, folks who smoke are at higher risk for osteoporosis, for fracture, but also for reduction in healing rates once a fracture has occurred. We want to avoid excessive alcohol intake. The risk for osteopenia is much higher, and the risk for falls is much higher for those who are excessively drinking. We want to maintain an healthy lifestyle. We want to make sure that we're active at home, we're going to the gym, we're walking, trying to keep those bones and those muscles really strong and reduce the risk for falls. With your patient, you want to review some of the methods to reduce falls at home. Removing rugs and carpets, keeping adequate lighting, making sure that we're safe on the stairs, the bathroom is safe, as well as if you have pets, to consider using a bell so that that pet, if they're down below the patient, that they understand that the pet's there and not trip over that cat or dog. So other keys to prevention. We want to consider secondary causes of low bone mass, of osteoporosis. And it's estimated that about 1 in 3 women have a secondary cause. What are they? Well, these are the secondary causes here: hyperparathyroidism, celiac disease, Crohn's, HIV, hyperthyroidism, as well as Cushing's disease. About 80% of your secondary cause is going to be hyperparathyroidism. We all check basic metabolic panels, but if you see an elevated calcium on the metabolic panel, I would consider checking a vitamin D as well as a parathyroid hormone level. A high PTH, absent of a low vitamin D level with high calcium levels, is primary hyperparathyroidism, and would consider treatment, especially if that patient has a low bone mineral density. Celiac disease, it reduces absorption, in particular vitamin D levels, and so if you see a very low vitamin D level in a patient, I might consider a workup for celiac disease. Crohn's disease also reduces absorption, HIV hyperthyroidism, as well as Cushing's disease, change that bone turnover. Obviously a TSH for the thyroid, but for Cushing's disease, if the patient has hypertension, diabetes, is exhibiting signs of Cushing's disease, I might consider that low-dose 1 milligram dex suppression test, where you give them one pill of dexamethasone 11 p.m. the night before, and then check that AM cortisol, serum dexamethasone, and ACTH the next morning. If that is suppressed, then they don't have Cushing's disease. All right, so that's secondary causes. Also, just a quick word on proton pump inhibitors, reducing the absorption of calcium. We might see an increased risk for fractures for those who are chronically using proton pump inhibitors, about a 29% increased risk for fracture. That is not seen in the histamine receptor 2 antagonists, although it kind of trends in that direction, at least amongst all these studies pulled together, did not show a statistically significant increased risk for histamine receptor 2 antagonists. How about the diet? How about nutrition? Well, there's really no evidence at this point to recommend a specific diet to prevent bone loss. There is, and I didn't include it, but actually there's a couple of studies now such as prune intake might actually reduce fracture risk. But generally, we do want to ensure that we're getting adequate calcium and vitamin D primarily through the diet and not through supplementation. I'm going to give you a little bit of data in terms of the vitamin D story here moving forward. But if the patient does have a low 25-hydroxy vitamin D level, less than 20, I might still consider treatment because we start to see rising levels of parathyroid hormone. That parathyroid hormone can leach the calcium from the bones and increase the risk for fracture. I want to consider protein, an adequate amount of protein, especially for those with normal kidney function, ensuring that we are reducing sarcopenia and frailty, keeping those muscles strong, reducing the likelihood of fall. How about exercise? Well, generally, we want to recommend any form of exercise for reduction in the risk of multiple chronic diseases. But really, the exercise that has been shown to really improve the bones for the prevention of osteoporosis is this high-intensity impact resistance training. These are like squats and deadlifts and big jumps and everything. And it's been shown that in women with osteopenia that it actually strengthens those bones and reduces the risk potentially for fractures. But again, we want to consider balance training, walking, any form of exercise at least twice weekly, but honestly, probably at least 5 times weekly. All right, story regarding vitamin D. And this data is actually not in women, but a observational study over time, over 5 years in men. I just wanted to paint the vitamin D picture here, that over time, this is total hip, femoral neck, and trochanter as you move to the right. And these are varying levels in the bars of vitamin D. On the left is the lowest vitamin D group, and over on the right is the highest vitamin D level group. And you can see that over time, over this 5-year period, those with very low vitamin D levels actually have the greatest loss of bone mineral density. So really kind of setting up the picture that we want to make sure that our patients have an adequate vitamin D. Now, with that said, the data really are kind of modest in terms of the benefit of both calcium as well as vitamin D. And this is from the Women's Health Initiative that I think you're all very well aware of, but a trial looking at calcium and vitamin D versus placebo. Calcium and vitamin D supplementation is blue. In red is placebo. And you can see bone mineral density of the total hip on the top, total spine on the bottom. You see benefits with calcium and vitamin D in the total hip, but not in the total spine. Ultimately, though, we want to prevent a fracture. We're not quite as worried about the bone mineral density, right? We want to make sure that we're preventing a fracture. And interestingly, there was no benefit with calcium and vitamin D as compared to placebo in the Women's Health Initiative. One other study that I think ultimately now is the tiebreaker for vitamin D was the VITAL trial, which you probably have all seen. This was a 2x2 multifactorial study in men and women, actually as a primary endpoint looking at cancer rates as well as cardiovascular reduction, looking at both omega-3 fatty acids as well as vitamin D. And in this study, obviously some of the patients received vitamin D, 2,000 international units on a daily basis. And what they showed that as compared to placebo, the vitamin D group actually had no benefit in non-vertebral fractures nor with total fractures. So really kind of flipping the script in terms of kind of potentially reducing the need for the intake of supplementation of vitamin D. Interestingly, it did not matter starting age, gender, ethnicity, nor, and this kind of throws kind of some of the earlier data that I showed you away, but even at very low vitamin D levels, replacing with vitamin D actually had no impact on fractures. So, at this point, the United States Preventive Services Task Force and the Endocrine Society, these are the newest recommendations just from this last year. Up in Salmon is the Preventive Services Task Force. They actually recommend against the use of vitamin D for the prevention of fractures, as well as for the prevention of falls in community dwelling postmenopausal women and men. Down on the bottom, the Endocrine Society also recommends against the general use of vitamin D, but there is a little bit of data for vitamin D in those who are older and reducing the risk for falls. And so the Endocrine Society did make one adjustment. They said for those men and women over the age of 75, you can consider vitamin D supplementation to reduce, the risk of mortality, but also for falls. All right, so that's the data for vitamin D. So I want to step back just a little bit and just remind you in terms of bone mass. So men and women achieve peak bone mass in their 20s. Men ultimately a little bit more, and less of a loss over time because men continue to secrete testosterone, which is converted to estrogen, and so you see less of that bone mass loss over time over the aging process. But in females, as we obviously know, we see more of an abrupt loss of bone during menopause. I think this is a really interesting study, the SWAN study. It's a little bit older now, but it's from about 15 years ago. As we all know, we see this kind of abrupt loss, the great majority of bone mineral density loss kind of during this 10-year window surrounding menopause, both for the spine as well as for the hip. But interestingly, in this one study, it was shown that over this three-year window surrounding the final menstrual period, that we see actually 70% of that bone loss kind of during this very short window. And so the question is are there things that we can do potentially to prevent fracture risk during this time period? And I might consider estrogen, and especially in your younger population where there is a favorable benefit to risk profile, where we do see in the Women's Health Initiative reductions in both hip and spine fractures with the use of estrogen. So might strongly consider it. So moving on to now screening. The U.S. Preventive Services Task Force does recommend screening for women 65 years of age and older. Again, the screening is through a DEXA, through a bone mineral density testing, or if one is younger than 65 with one or more risk factors. Those risk factors include a family history, smoking history, rheumatoid arthritis, lower BMI, might consider osteoporosis screening at an earlier age, and insufficient data in terms of screening for men. How many of you use FRAX? Great. So in conjunction with bone mineral density testing, the recommendation is to use one of these screening tools such as FRAX. FRAX uses both clinical factors and a DEXA to come up with a 10-year probability of a major osteoporotic fracture as well as hip fracture. You can go online, and I would put in for the United States if you're practicing in the United States, but you can go in if you're practicing in a different country because they set out different criteria for the treatment of osteoporosis. But it's a questionnaire with a number of factors: age, gender, weight, height, a bunch of clinical factors, as well as you do also have to input the bone mineral density. You have to make sure that you have the right company as well. And this will spit out a 10-year risk probability for you to consider treatment, and I'll review that here shortly. Also, just want to briefly mention that FRAX, for those of you who are using FRAX, it actually is not very good once a woman is over the age of 80. So generally, you are looking at clinical factors, have they fractured, as well as bone mineral density for those who are over the age of 80. All right, so before I move on to the actual treatment of osteoporosis, I want to just talk through the basics of bone physiology, which I think you're all aware of. For that healthy young woman, we see this kind of equal parts bone resorption and bone formation. So as a reminder, the skeleton actually turns over once every decade, right? You lose bone, you put bone back through the osteoblast. This equal resorption and formation leads to healthy bone. But as one ages down the bottom, we see increase in osteoclast activity where there's this resorption of bone, and a reduction in osteoblast activity where you have this bone formation, which ultimately leads to risk for osteoporotic fractures. All right. So how do we, knowing that, how do we then risk stratify our patients ultimately to determine whether or not one needs treatment as they are aging? Well, we think of a kind of a low, moderate, high, and very high risk. And again, these three factors, I just kind of want to focus in on it. Bone mineral density, that DEXA, history by fracture. Has the patient had a low trauma fracture in the past or more recently? As well as what is the fracture probability by FRAX. Using these three criteria, you can ultimately come to a decision on whether or not the patient needs treatment for osteoporosis. So what are the indications for the use of pharmacologic agents? Well, osteoporosis range bone mineral density at any site. It doesn't have to be at all sites. It can be at any site. That minus 2.5 standard deviations or lower. Osteopenia ranged bone mineral density. So just because you have osteopenia on a DEXA does not mean that the job is done and that we would not treat. Because if they have osteopenia with a high predicted probability fracture on FRAX, in the United States it's 20% or greater for a major osteoporotic fracture, as well as hip 3% or greater, the recommendation is to treat. Or if they've had a prior low trauma vertebral or hip fracture. And this comes from kind of multiple societies, the National Osteoporosis Foundation, the Endocrine Society, as well as the American Association of Clinical Endocrinologists. All right, so what do we have in terms of treatment? So I'm more or less going to skip over the SERMs, estrogen and calcitonin, but really talk a little bit more about our workhorses, the bisphosphonates, and our rank ligand inhibitor, denosumab. These are anti-resorptive agents. They, again, inhibit those osteoclasts from resorbing bone, allowing for stronger bones. But we also have, and not necessarily, I would assume that you guys are not endocrinologists and probably not using these medications quite as consistently, but we do have our osteoanabolic agents, our parathyroid hormone analogs, teriparatide and abaloparatide. And the newest, about 6 years ago, approved our osteocyte-derived sclerostin antibody, which is romosozumab. And just going to give you a little bit of data regarding those over on the right later on. So we have these patients, low, moderate, high, very high risk categories. Generally, the recommendation is low and moderate risk, not to treat. As we move into high risk, again, this is osteoporosis, a fragility fracture, or a high FRAX score. We recommend a bisphosphonate, alendronate, risedronate, or IV zoledronic acid, or denosumab, which is, again, the rank ligand inhibitor. As the patient is moving into a very high-risk category, we either will consider a stronger bisphosphonate, such as zoledronic acid, or may potentially move into our osteoanabolic agents, teriparatide, abaloparatide, or romosozumab. At this time, the American College of Physicians, in terms of starting treatment, does still recommend this bisphosphonate, the rank ligand inhibitor, to reduce the risk for hip and vertebral fractures in women with known osteoporosis. In men, there is data suggests that bisphosphonates also will reduce the risk for vertebral fracture. All right. Very busy figure here, but really what my hope is to provide you just kind of a reminder that the reason why we don't use our SERMs and our calcitonin is they're really not broad spectrum benefit across the board beyond reducing the risk for vertebral fractures, no benefit at the hip. We do see benefit with denosumab across this wide spectrum, which is part of the reason why we would consider the use of this medication. And then our bisphosphonates here, we do also have wide spectrum benefit minus abandronate. The clinical trials for our newer agents, the osteoanabolics, romosozumab, really have not been powered to look for hip fractures, and so really not great data in terms of that beyond vertebral fracture risk prevention. Again, very busy. I'm going to kind of skip through this, but the pivotal trials for alendronate, risedronate, zoledronic acid, and denosumab, again, these kind of first-line therapies that we might consider for the treatment of osteoporosis. What they have been shown, though, is they're really strong in reducing the risk for fracture. So they reduce vertebral fractures by 50%, non-vertebral by 20%, and hip fractures by about 40%. So these medications are excellent in reducing the risk for fracture. So generally speaking, and don't look at the slide yet, but generally speaking, the recommendation is with denosumab or one of our oral bisphosphonates to treat for about 5 years of therapy and then reassess. That's kind of the general set of recommendations. Once we've put a patient on these medications, treat for 5 years. Now, there is some data, and generally speaking, the IV zoledronic acid, this IV bisphosphonate, we generally will treat for 3 years. This is data, I believe, from the Horizon trial from Black and colleagues, in which they placed patients on IV zoledronic for the first 3 years. You can see that the bone mineral density rose with all of these. Then in the dotted gray line, there was a stop of zoledronic acid, continued in the black line, and you can see actually continued benefit for bone mineral density, even for that IV zoledronic acid that was discontinued after 3 years. So generally speaking, the recommendation is to stop zoledronic acid after 3 years of treatment and reassess. And I'm going to kind of go through this in terms of a few patients to discuss kind of the treatment of this general fracture risk reduction. So this is a 69-year-old female with osteoporosis who's now completed that kind of general treatment of 5 years of alendronate therapy. She's had no fractures on therapy. Her T-scores pre-treatment, she had osteoporosis at the lumbar spine, some improvement, actually clinically significant improvement in her T-score in the lumbar spine post-treatment. Her FRAX score, so we calculated her FRAX score, her major osteoporotic fracture risk is 12%, and her hip is 2.7%. As a reminder, kind of these magic numbers are 20 and 3, so she actually does not meet criteria of high risk from a FRAX perspective. So what are the next steps in treatment? I like this. This is old. This is about 10 years old from Adler, but really a great figure in terms of a decision tree on what we do in terms of the next steps in treatment. So we've treated our patients now for 5 years up on the top of alendronate therapy. You can consider, again, 3 years of IV zoledronic acid. The first question is has the patient had a hip, spine, or other osteoporotic fracture before or during therapy? And for this patient, the answer is no. We move to the right. Does this patient have a low BMD score? Does the patient have a high fracture risk? Again, the answer is no. So now we move down to the right, and for this, we would consider a drug holiday for 2 to 3 years. So why might we consider a drug holiday? Well, the first are these atypical femur fractures that I mentioned early on. These are infrequent, but quite terrible in nature. And these are transverse fractures, lateral cortex, they become oblique. These require surgical fixation, lots of pain, decreased quality of life, as well as mobility. And so these are fractures that we do want to prevent. Now, with that said, the incidence is quite low, very low number per 100,000 person years, but they are duration dependent. And this is the reason why we might consider a bisphosphonate holiday, is that the longer we treat with the bisphosphonate or denosumab, our RANK ligand inhibitor, we start to see a rising risk for these atypical femur fractures. And we do know that risk does drop as therapy stops, and we give these holidays. Those patients who are at high risk for atypical femur fractures are those who have used steroids, those who are Asian. But I want to just focus in on just kind of how rare these are. So despite the fact that we are thinking about these atypical femur fractures, it's been estimated that for every 150 fractures that you prevent for osteoporosis or fragility fractures, you're probably going to see two of these atypical femur fractures. So you really still are preventing a high number of fractures by treating with your bisphosphonates. All right, the next is osteonecrosis of the jaw, or ONJ. So this is exposed bone that does not heal within 2 months after exposure to an anti-resorptive agent and no history of radiation therapy. The incidence, again, is very low. But this, and I think you all are aware, is this is an oncology-based disease process. So for our patients who receive 6 to 10-fold dosing of bisphosphonates, this is where we see osteonecrosis of the jaw. We very, very rarely see it in those who are treated at the lower doses of bisphosphonates and osteoporosis. Additionally, well, if the patient needs to undergo any oral surgery, would recommend for that oral surgery to occur before the bisphosphonate therapy. But if a patient is on a bisphosphonate, the American Dental Association 15 years ago actually recommended against stopping a bisphosphonate due to the very low likelihood for ONJ. All right, so we move on. So kind of going back to the suggestion of this bisphosphonate holiday, so just some practical suggestions. For some of these patients at low risk, there's little justification for use of bisphosphonate for greater than 5 years and to reassess. The data over on the right here is data from the FLEX trial, again from Black and colleagues, that after 5 years of alendronate therapy, in the darker bolded black line are those patients who continue to bisphosphonate versus in the lighter black line. You can see here that over a 2-year period, both there was some rise in vertebral fractures, but still a very low risk for the incidence of vertebral fractures, even those who are on a bisphosphonate holiday. And it was not statistically significant in terms of the difference between the two. So again, the risk for fractures is very low, even if you're going to stop that bisphosphonate for 2 to 3 years at a time. But as we've stopped, we want to reassess clinical risk factors. We want to assess FRAX on an annual basis. We want to ask if the patient has had a fracture, and then reassess a DEXA every couple of years. We actually will reassess a DEXA at the end of treatment, and then every 2 to 3 years, you're going to reassess that bone mineral density to reevaluate that risk. And once their fracture risk is high again, want to consider treatment. All right, what do we have in terms of, again, the medications? We have our bisphosphonates and our RANK ligand inhibitor, denosumab. They are given the bisphosphonates either as an oral or injection, RANK ligand inhibitor as an injection. Generally, bisphosphonates we want to shy away from if the GFR is less than 25 to 35 for fear of adynamic bone disease and the increased risk for fractures. The side effect profiles are pretty similar between the two in terms of GI symptoms, atypical fractures, ONJ, hypocalcemia risk. So for those patients who you're putting on this medication with low vitamin D levels, there is some risk for hypocalcemia. So I'd make sure that their vitamin D level is relatively robust. So if you're going to consider the treatment of one or the other, what might you consider? Well, this is a comparison of multiple randomized clinical trials between the two classes of medications. The denosumab actually fared better in terms of increasing bone mineral density compared to the bisphosphonates. But again, as I previously mentioned, it's not all about the bone mineral density, it's about fractures. And there really, at the end of the day, really very little difference between fracture rates between the two classes of medication. So you really can consider what you and the patient are more comfortable in using. I think a little bit unfair, but more recent data just from this last year, comparing the bisphosphonates and denosumab. This is real-world data. This is not clinical trial data. This is not head-to-head data, and so it's a bit biased in terms of the prescriptions that are provided. But again, amongst those patients who either prescribed denosumab or alendronate, denosumab being in blue, alendronate being in gray, the cumulative risk for any major osteoporotic fracture was lower on denosumab, and then the risk for hip fracture was also lower on denosumab. So take that as you wish. Again, real-world data, but not head-to-head clinical trial data. All right, the denosumab. So we can use denosumab for up to 10 years, especially for those higher risk patients. You can see here, this is data from the FREEDOM trial. Initially in lighter blue, patients were treated actually for the full 10 years. You can see this rise on the left with lumbar spine and total hip on the right of our increasing bone mineral density. In green was the second arm, or actually the other group of patients who were given placebo for the first 3 years, and then given denosumab in this crossover. And although they did not catch up, we see this rise also in bone mineral density. So this is all in good. Again, you can treat for 5 years, higher risk for 10 years with denosumab. But I want to just focus in on any of you who have prescribed denosumab probably understand the risk of discontinuation. So this is a 68-year-old female with a history of breast cancer who now in the last month has had 4 vertebral fractures. She was initially diagnosed with breast cancer, placed on an aromatase inhibitor. She received denosumab, which is actually oftentimes paired with a aromatase inhibitor. But denosumab was stopped 1 year earlier. Prior to treatment, her lumbar spine was in an osteoporosis range. That did improve post-treatment. But I just want to show you this data from the FREEDOM trial. So just focus in all the way over to the right. In that gray area is the 1 year in which patients were right after the discontinuation of denosumab. And you can see this just really abrupt and very large loss in bone mineral density after denosumab has been discontinued. It's not just the BMD, but also we see an increased risk for fractures once the patient has stopped it. So in the gray bars are the fractures. of a vertebral fracture and then multiple fractures over on the right. And you can see here just this kind of really large rise in vertebral fractures once a patient has been discontinued for denosumab. So I think this is really important to understand. And there is some data, and I'd like to present this one. This is out of Greece, that we do want to transition to another medication. So if you are stopping denosumab, you want to transition them over to a bisphosphonate. And this is the reason why here. So in this study, they took two groups. Both initially took 2 years of denosumab treatment. Then the first group continued denosumab for 1 year. The second group continued IV zoledronic acid, a bisphosphonate. Then after 1 year, what happened is the denosumab group actually stopped. So they did not give any treatment after denosumab was stopped. You can see here this kind of abrupt loss of lumbar spine and femoral neck bone mineral density in the black circle, whereas those who continue with IV zoledronic acid or bisphosphonate really mitigated the loss of that bone mineral density. So I would consider any form of bisphosphonate, oral or IV zoledronic acid for the treatment if you have a patient who's been on denosumab, and especially if you're seeing them and they're now they're fracturing, I would absolutely get them on to a bisphosphonate. All right, so how about our high-risk patient? This is a 75-year-old female with hypertension, osteoporosis. She has a DEXA, DEXA, who's received alendronate now for 5 years. She had a traumatic, not a fragility fracture, but a traumatic ankle fracture at the age of 53, and no fractures while on treatment. She has osteoporosis range T-score at the lumbar spine, post-treatment minus 2.5, and her FRAX scores now are above that kind of 20 and 3%, right, at 23 and 6.8%, suggesting a very high risk for fracture within the next 10 years. So what are our next steps in the recommendation for treatment? Going back to Adler here, and as you kind of go down this decision tree, she does have this kind of, as you move halfway down, this high risk moving over to the left. And the recommendation for these patients who still are at relatively high risk with a low bone mineral density or a high FRAX score, the recommendation is to continue treatment with a bisphosphonate, maybe move them to denosumab, maybe move them to a stronger bisphosphonate such as IV zoledronic acid, or the possibility of an osteoanabolic agent. So I just want to briefly kind of talk through these agents, not with the expectation that you would prescribe them, but just kind of as a reminder, what are the benefits, what are the potential downsides of these anabolic agents? The pictures really speak a thousand words here. Teriparatide on the left, romosozumab on the right, placebo versus the active medication. You can actually really physically see the difference in bone formation with the use of these medications. So what do we have? Again, very busy, but teriparatide, abaloparatide, and romosozumab over on the right, approved in 2002 and 2017, and then romosozumab, our latest agent, approved about 6 years ago. They increase bone formation. The abaloparatide and teriparatide do not decrease bone resorption, whereas romosozumab actually has dual activity, not only increasing bone formation, but also decreasing osteoclast activity. These medications are given as subcutaneous, either daily or monthly. Again, injections can be given by the patient or by the health professional, and they can be given for up to 24 months for teriparatide and abaloparatide, and for a year, possibly with another year extension for romosozumab. They are indicated for postmenopausal osteoporosis, but again, reserved for those patients who are very high risk for fracture who have already fractured. Some of the potential downsides of these medications, those patients with osteosarcoma would absolutely stay away from teriparatide and abaloparatide. And then in the pivotal clinical trial for romosozumab, there was a higher risk for myocardial infarction. So the recommendation is, so for patients who have had either a stroke or a heart attack within the last month would not use romosozumab. All right, so those are the contraindications. All right, so just a last couple of slides here. In terms of monitoring for response in pharmacotherapy, again, our serial bone mineral density really is the workhorse for both kind of the diagnosis of bone mineral density as well as monitoring. One of the questions always is how frequently do we monitor, what will be accepted by insurance, what will be paid for. But I will remind you that although we use bone mineral density, the majority of the efficacy of bisphosphonate actually are not captured by the bone mineral density testing. It is really more based on clinical criteria. In terms of testing, we do recommend about every 2 to 3 years. Sometimes once a patient is started on osteoporosis therapy, the recommendation, if you're worried that, especially if they're very high risk, you can check 2 to 3 years into therapy. And if they are either stable or gaining bone, you are happy. If there is an abrupt loss in bone mineral density 2 years into treatment, you may want to reconsider the medication, may want to ask the patient, are they taking it consistently, especially those oral weekly medications are not easy to take, and are they absorbing it? And so would consider kind of a reevaluation with the patient. And if the bone mineral density is worsening, I would also consider secondary causes. If you have not undergone that workup for secondary causes of osteoporosis, would check for hyperparathyroidism as well as others. One of the other questions that I get are related to bone turnover markers. And really, there's no prospective trials that have really defined an optimal approach to our bone turnover markers. I might consider it in evaluating for treatment response. So again, for those patients who have had a DEXA, that DEXA is dropping despite treatment, evaluating with bone turnover markers. If they are high, they are either not receiving the bisphosphonate or the bisphosphonate is not being absorbed, and might consider a different medication based on those bone turnover markers. All right, so just a few take-home points. Again, fractures portend significant morbidity and mortality, especially those hip fractures. About 1 in 4 people are at risk for mortality or death in the first year. It is vital to assess for osteoporosis, again, in women who are 65 years of age and older, and we want to do it through multiple modalities: bone mineral density testing, history, has the patient had a fracture, as well as your FRAX score. Those 3 really ultimately will help decide on whether or not the patient requires treatment. Our anti-resorptive agents, the RANK-like inhibitors, and the bisphosphonates are first-line therapies, and we want to reassess 3 years into treatment, and especially after treatment, after 5 years of treatment, and assess whether or not they may be at lower risk. We can use a bisphosphonate holiday, or if they're at high risk, continue medication. But again, surveillance is key, ongoing through the years. This is not a diagnosis that we can cure. This is one in which we continue to treat as a chronic disease. And then just as a reminder, denosumab discontinuation must be followed by a bisphosphonate. And our osteoanabolics are available under certain circumstances, but really they do need to be followed with a bisphosphonate, and these again are reserved really for higher risk patients at very high risk for fracture. So hopefully I have made some sense of osteoporosis treatment. I think we're reserved questions after at least 1 or 2 more lectures, and I'll come back after that, but thank you very much.
Excellent slides, by the way. I love the graphics, and they were all clean and neat and well done. We're in for a treat. I've had the opportunity to do meetings before with Tammy, Dr. Rowan. She is an associate professor in the Department of Obstetrics and Gynecology and Reproductive Sciences. She's completed her medical school training and residency at UCSF with a master's in health and science from UC Berkeley. She's the director of sexual health programs and perioperative medical director for UCF's Department of OBGYN. She's currently the secretary and past education and scientific chair for the International Society for the Study of Women's Sexual Health. She's a former associate editor and currently on the editorial board for the Journal of Sexual Medicine. She's authored dozens of publications, including peer review book chapters on topics including sexual health, surgical care, family planning, and international maternal health. Once again, I love patient comments. They say you are knowledgeable, warm, and you listen fully, which is remarkable. And Tammy has taught me a tremendous amount about menopause and sexual health. So thanks for being here.
I was thinking I love the chair of my department, but this man is probably a phenomenal chair because he really does know how to prop people up, It's great. So I am super excited to be here, and I feel like talking about menopause is a really nice segue from the osteoporosis talk, because I'm not going to talk about osteoporosis, but I will mention it. And we already learned that osteoporosis really accelerates at menopause, so it really is fitting here. How many people have been online or in social media and seen something related to menopause in the last 6 months? Thank you. All right. So as we know, we keep saying menopause is having a moment. Well, the truth is menopause has always been here. I find it really fascinating that we somehow need specialists and we need all this extra training in our field, even though there is literally no condition in OBGYN that 100% of people will go through except for this one, right? Why do we need to be a specialist in this? Why do we need extra training? Why are we not learning this, right? We know all about pregnancy. Not everyone's going to be pregnant. We know all about abnormal bleeding. Not everyone's going to go through that. There is no human being with ovaries who will not go through menopause. So we only have 45 minutes. You guys probably know that there is a whole day course that Symposia is now putting on in New York. I hope to see you there. We give weeks, days and days long talks on menopause. So I'm going to give you a little taste today of some of the basics, the questions that we often get. Because this is a Zoom hybrid lecture, we are not going to get to do the audience response, but I will have questions throughout this lecture that I want you to think about, and I'm going to ask for your answers in response. There's no judgment, right? I'm not here to quiz anybody. I learn through people asking me questions and thinking about the answer, so I hope that will be helpful. These are my disclosures. Okay, here's what we're going to do. We're going to talk about what menopause is. People actually don't know what it is. I get this every single week in my clinic. We're going to talk about the hormonal changes that lead up to it. You will notice that I'm a very physiologic and evidence-based person. I'm going to show you a lot of data. I am not someone who really typically says this is what you should do without explaining the why. The why is really important, and I think our patients need to know that. Even if you're not academics, they're going to come to you and say, there's a study that shows this. That means that. You need to give me X, Y, and Z treatment. And your job, or our jobs, is to say, actually, let's take a step back and talk about that there's a broad body of evidence. And again, group data might be a little different than individual data. And so we want to be really person-centered, but also really think about really what are the risks and benefits to various treatments. Not all treatments are hormonal. All anyone wants to talk about now is hormones are the greatest thing ever. They are great. They do amazing things. They're not for everybody, and they're not for everything. So we're going to talk about what they're good for, what they're not good for based on the evidence, and then some non-hormonal options as well. First question, what is menopause? Is it the time starting after the first menstrual period, the time starting 1 year after the final menstrual period, the time when FSH levels go above 25, the time when AMH levels drop below 0.1, or all of them? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? Who thinks it's E? A couple can't vote. Great, okay. Well, so the good news is most of us are on the same page. What menopause is 1 year without a menses, okay? Everything leading up to that is premenopause or perimenopause. Menopause is when you are 1 year without. Now, there's a problem here. There are people who don't get their periods. There are people who are on birth control that suppress this process. So how do we define it for them? And really, the way you diagnose it is with 2 levels of follicle-stimulating hormone, not one. I'll have patients come in and they'll say, a year ago I was tested, my FSH was 30, I was told I was in menopause, and then I got a period. You're not in menopause. Or you didn't get a period and it's been 6 months. You're not in menopause. It's if you have no reason to be menstruating, 2 FSH levels have to be above 25. Another commonly mentioned hormone is anti-Mullerian hormone. Remember, that's the hormone that follicles make, so they're in the eggs. It's a marker of how many eggs there are. When you don't have a lot of eggs, you're going to have a really low AMH. But the levels at which you would need to detect menopause or predict when menopause is going to happen, AMH, we don't have the sensitivity for that, right? We will say for reproductive age people, if your AMH is less than 0.1 or less than 1, you might have low ovarian reserve. I can talk about AMH all day long. I'm sure Dr. Bates will. It is not a fertility test. It does not tell people if they will get pregnant. It just tells them how many eggs you might get out if you froze your eggs or did IVF. That's been proven. All right, there is no role for testing hormone levels in perimenopause. If you have a period, I'm so glad that I'm in good company. How many times do we spend, right, like just, how long with our patients being like, there is no role, and I'm gonna tell you why. So the key thing about menopause is just the menstrual cycle. So this is the graph that I use. I use this for lots of different OBGYN conditions. So, I'm a sexual medicine person, but the cool thing about sexual medicine is everything we do in OBGYN affects sex, right? So you can't be a sexual medicine person without being a menopause person because sexual dysfunction peaks in menopause. So you become that. You become a pelvic pain person, right? But I do a lot of, and I love hormones. I would have been an REI if I could handle telling people they weren't pregnant. That's too emotional for me. But I love the endocrinology of this. So I'm just gonna go over the menstrual cycle with you guys real quick. So in the menstrual cycle, the reason I like this graph is it breaks it up. The way I explain the menstrual cycle is it is a cycle that occurs at the level of the brain, the ovaries, and the uterus. There are 3 different parts. So at the start of the menstrual cycle, all the hormones are low, and I don't have a pointer, I believe this doesn't point, but I wanted to, if I were, I'd be showing you. So there's the pituitary hormones, that's your follicle stimulating hormone, and your luteinizing hormone. The way I think a follicle stimulating hormone is how hard is the brain working to tell the ovary to get an egg ready and make estrogen, right? That's why if it's working really hard because there's no eggs left, it's high. That's how we diagnose menopause, right? That's how we diagnose potential fertility or diminished ovarian reserve. At the level of the ovary, you're gonna see at the beginning of the cycle, all the hormones are low, so that's why when we want normal ovarian function, we actually want a low estradiol. If your estradiol is high on day 3, you got a problem, right? And you actually can't interpret the FSH. And this is a mistake that a lot of GYNs make, where the FSH looks normal, but the estradiol is high. If it's above 50 on day 3, it's not interpretable, and it's actually a sign of diminished ovarian reserve. So you want low estrogen on day 3, but then you see it start to go up, and estrogen builds the lining of the uterus, right? So that's its job. It stimulates the lining. We're all familiar with that. Halfway through the cycle, when a follicle is ready in an ovulatory person, the egg is going to release, and then the corpus luteum takes over and makes progesterone. You cannot have progesterone without ovulation. This is why when people come in and they're like, I'm in perimenopause, my progesterone is low, I'm estrogen dominant. You're like, yeah, because you're not ovulating. That's like a hallmark of perimenopause. If you're not ovulating, you're not going to have progesterone. Normal, right? And then at the end of the cycle, if you're not pregnant, the corpus luteum shrivels up, estrogen drops, progesterone drops, and you bleed. And the bleed is in response to the drop in hormones. And the reason I love this is when people have any kind of reproductive mood issue, PMDD, PMS, PCOS, I will get out this cycle and I will show them. And this is from Up to Date, if you guys want to know where you get this from. This is the Up to Date one. If you look at most graphs, this is where I get nerdy, they always overlap the ovarian and the pituitary hormones. And it's really annoying and it's distracting. So I like this because it separates them. Okay, I got some busy slides. The takeaway is when we talk about the reproductive life, what are we talking about, right? We're talking about the reproductive cycle, right, before perimenopause. What are our hormones doing? So you see a variation in FSH. You will see kind of normal, not super high, we call it low AMH. And then in the perimenopause, you start to see things change. So FSH starts to rise, AMH gets lower, the follicle count goes, and then you start to get vasomotor symptoms. And then what's going to happen, kind of the key is when you go through menopause, things start to stabilize. So when we talk about perimenopause, what are the hallmark lab findings that we're not testing for, but when someone comes in and shows you their labs, what do you expect to see? Low estradiol, low FSH, low progesterone, high estradiol, low FSH, high progesterone,